Hey guys, my name is Shrey Gadigankar and today I'm going to be talking about pulmonary embolism. So, yeah. So what is pulmonary embolism? So it's basically defined as a sudden obstruction in the pulmonary artery by a material that gain access to the venous circulation and passed to the pulmonary circulation, eventually reaching arteries with a small diameter where it forms a plug. So this typically involves deep vein thrombosis. So we usually have a DVT, which embolizes. As a result, it comes from like for instance, the lower extremities, for instance, the femoral vein, and it embolizes into the venous circulation and goes to the heart. And from there, you have obstruction of pulmonary arteries. As a result, you can see it may clog up certain arteries, and you may have infarction as a result of this. So epidemiologically speaking, this is it's a major cause of death in 10% of patients who die acutely in hospitals. So regarding the etiologies, um, one of the most common is thrombus. So usually from a deep vein thrombosis. Um, and this involves a Volkov's triad. So I'm pretty sure you guys have heard of this. So this involves what is known as a triad. So you have a hypercoagulable state. You may also have endothelial dysfunction, which is the second one. And thirdly, you may have venostasis. So, for instance, if you talk about hypercoagulable states, one of the most common kinds of this is common types of this is lead-in factor 5 mutation, which is a type of thrombophilia. So this the patient has the increased risk of developing thrombosis. The patient also may be pregnant, so that's a hypercoagulable state, and the patient may also be consuming oral contraceptives, so that's also increase the risk of thrombus formation. Um, Apart from that, you can also have certain other kinds, like for instance, in the case of endothelial dysfunction, usually due to inflammation or trauma. And finally, you have venostasis, which is, for instance, immobilization for prolonged periods of time. Um, Thrombus may also form because of, for instance, cardiac diseases in the cases of congestive heart failure, which is associated with venostasis. There may be disseminated cancer, prolonged bed rest, which is basically immobilization again. There may be patients with hip fractures as well as patients with severe trauma, like, for instance, other kinds of fractures or even burns. So that's just for thrombus. The second one is fat emboli. So these fat emboli usually occur due to some kinds of long bone fractures or even during liposuction procedures. And these are basically the patient usually presents with the classic triad of hypoxemia, neurological abnormalities, and a petechial rash. There might be air embolism, specifically in divers, where the nitrogen bubbles precipitate in divers who ascend too quickly, and this is what is known as the bends. Uh, you may also have, so this is basically a kind of decompression disease. You may also have a chronic form of bends, which is basically associated with avascular necrosis of the femoral head. And other kinds of air embolism are usually iatrogenic, which is basically where it's induced because of hospital procedures or because of doctors themselves. And this could be like a complication because of certain kinds of invasive procedures, like a central line placement. Uh, the other etiology is the bacterial, for instance, and amniotic fluid as well, usually postpartum, which is after pregnancy, and this can lead to disseminated intravascular coagulation. And finally, you have through tumor embolus. So these are certain pictures of embolus. So in this, you can see in the fat embolus in this over here. Uh, you actually can't see the fat, and that's because it's usually removed due to the process of fixation. But you could see the spaces in which the fat would reside in. You can also have a tumor embolus, as mentioned. So you have the tumors over here as well as over here. If you zoom in closely, you can actually see that it's because the tumor is a chondrosarcoma. So you might see the chondrocytes in the picture, and you also have amniotic fluid embolus. So that's basically this thing over here, and these. these lines are basically the embolus, the amniotic fluid embolus, and these basically contain these squamous cells from the fetal tissue. Regarding the clinical features and complications, so the pathophysiologic consequences of pulmonary thromboembolism, they depend largely on the size of the embolus. So this in turn dictates the size of the occluded pulmonary artery and the resulting complication as a result. So regarding the clinical features, so these often present with dyspnea, pleuritic chest pain, as well as hemoptysis, which is coughing up of blood. The complication could involve respiratory compromise or hemodynamic compromise. So in respiratory compromise, there's usually ischemia of the downstream pulmonary parenchyma and the non-perfused ventilator segment due to the mechanical obstruction of the embolus. In the hemodynamic compromise, it's usually embolic obstruction, which causes increased resistance to pulmonary blood flow. Thus, you have increase in pulmonary artery pressure, which results in acute cor pulmonale, which is also known as right-sided heart failure. So it's important to note that the lungs are one of the very few organs that have a dual circulation. So infarction of the lungs in case of pulmonary embolism is quite rare. However, if infarction does occur, then it's usually because of usually a hemorrhagic type. So as mentioned, you usually have local hypoperfusion because of the pulmonary embolism, and as a result of that, you have damaged surfactant production, and eventually you'll have areas of lung collapse or atelectasis. And infarction will follow if the obstruction is usually at the periphery of the lungs. Regarding the pathology, so as mentioned, the consequences depend on the size of the embolus. So for instance, if it's a large embolus, the lodge may be in the main pulmonary artery, as you can see in this picture over here. And it can also be in the bifurcation. As a result, you have what is known as the saddle embolus. So basically in this picture, you can see the obstruction is at the bifurcation, and a result of which you have the saddle-shaped embolus over here. You can also have smaller emboli which travel to more peripheral vessels, and these can be clinically silent. So with time, they undergo like organization, and they basically embed themselves into the vascular wall. Uh, Apart from that, you could also have hemorrhage or infarction. So, for instance, it could be in patients with normal cardiovascular function. So, in these patients, in everyone, the bronchial arterial supply usually sustains the lung parenchyma, and therefore hemorrhage may occur, but there's no infarction. On the other hand, you can also have in patients with compromised cardiovascular function. So patients with congestive heart failure, for instance. So in these patients, you usually have infarction. So I have a picture of the pulmonary infarction, which is quite rare, but it does occur. So macroscopically, these are classically hemorrhagic, as mentioned. And after 48 hours, the RBCs, red blood cells, they begin to lyse, and the hemoglobin within the RBCs is basically converted to what is known as hemosiderin within the macrophages, and it becomes a characteristic color, which is red-brown. Uh, so these infarcts of the lung are usually small and roughly wedge-shaped, as you can see in this picture. Regarding the microscopy, so there's usually ischemic necrosis of the alveolar wall because of the infarction, and as well as the bronchioles and the vessels. You may have a septic infarct, which is where the embolus is associated with a neutrophilic response, and it's often intense and can sometimes turn into an abscess as well, which is pretty severe. Regarding the fate of the emboli, so you can have a couple of things that can happen with the emboli. So you can have no fate, which is basically where the patient dies either due to hypoxia or acute cor pulmonale. And this usually occurs when there's more than 60% of the total pulmonary vascular bed. Apart from that, you can also have lysis of the emboli. So this is often clinically silent, and that's because these are usually small. The bronchial circulation usually sustains the viability of the affected lung parenchyma, and the embolus itself is usually rapidly removed because of by fibrinolysis. You can also have organization, which is basically where the thrombus can basically incorporate itself into the vascular wall. And finally, you can also have progression, which is, for instance, uh, in if you have like 10 to 15% of cases, the obstruction of the small to medium pulmonary branches can cause pulmonary infarction. But recurrent emboli can also lead to chronic pulmonary hypertension as well. Um, Apart from that, you have the diagnosis. So in the examiners usually won't ask you about this, but I feel it's good to have some idea. And so you can have ACT pulmonary angiography. So this involves a computed tomography. You can have ECG changes, uh, which is known as S1 Q3T3. Out of all of these, I feel it's important to know the lab findings, especially the D dimer levels. So these are usually elevated in cases of increased fibrinolytic activity, and as well as in increased thrombus formation in the body, for instance, in DIC as well. And finally, you can also have ventilation perfusion scan. So these are the references used, and thank you for your time.